Welcome to another episode of Uncovering Bailey in Love with SnazzySurgeon.
Great to be here.
Today, we're doing a deep dive into breast carcinoma, specifically how it spreads and how it clinically presents.
Yeah, absolutely. This is really fundamental stuff, the bedrock of our practice as surgeons dealing with this disease every day.
Absolutely. A strong grasp of these pathways, both within the breast and well beyond,
Yeah,
directly impacts our surgical strategy. It helps us anticipate what we might encounter in the OR.
exactly. And being able to recognize the various ways this disease can manifest is key for earlier diagnosis and ultimately better outcomes for our patients. It's about pattern recognition.
Okay, let's get right into it then. Let's start with local spread. It's not just a simple contained mass, is it? It starts reaching out pretty quickly.
Definitely not simple. The tumor expands, infiltrating the breast parenchyma itself. But it doesn't just stop there. It can breach those boundaries and involve adjacent structures.
Like, what kind of structures are we talking about typically?
Well, we see it involving the skin, sometimes leading to ulceration, even those satellite nodules that can be quite concerning. Deeper in, it can involve the pectoralis major muscle, sometimes the serratus anterior, and in really advanced scenarios, the chest wall itself.
And I recall there's a role for certain growth factors in this local invasion process. Can you elaborate a bit on what we see there? What's driving it at a molecular level?
Right. The tumor microenvironment is, well, it's a hotbed of activity. The malignant cells release a whole variety of signaling molecules. Some key players are fibroblast growth factor, FGF, transforming growth factor alpha and beta, so TGF and TGF, and of course vascular endothelial growth factor, VEGF.
VEGF, yeah, we're very familiar with its role in angiogenesis, which I'm sure we'll touch on later when we discuss distant spread. But what's the story with FGF and PGF in this local context? How do they contribute to the invasion?
Well, FGF in particular is fascinating when we talk about local spread. It basically stimulates nearby fibrocytes to divide and transform into fibroblasts. And these fibroblasts then get to work laying down collagen. This is what we call the desmoplastic reaction, that dense fibrous stroma we often have to dissect through in breast cancer cases. It makes the tissue feel hard.
Right, that tough, almost scar-like tissue. It can certainly make dissection challenging sometimes.
It really can. And interestingly, the specific isoforms of FGF expressed by the tumor can sometimes predict the degree of this desmoplasia. There's even research suggesting it might influence response to certain stromal targeting therapies. Definitely an area to watch.
Interesting. So how does this collagen deposition translate to what we actually see clinically on examination?
Well, this collagen matrix isn't static. It actually contracts over time.
Hmm.
Within the breast, this contraction can exert tension on Cooper's ligaments, those suspensory structures that help maintain breast shape. So if a single ligament is affected, we might see just a subtle dimpling of the skin overlying it. But when multiple ligaments are involved, it can lead to more pronounced puckering or tethering. And importantly, this pulling force can also cause nipple retraction. You see that quite often in clinic.
Absolutely. That pulling action makes perfect sense when you visualize it that way. Okay, now let's move on to lymphatic metastasis. This is obviously a major determinant in our staging and management decisions. Where does the spread typically begin?
Yeah, hugely important. The primary route, the main highway, if you like, for lymphatic dissemination is to the axillary lymph nodes. These are the first-line regional nodes draining most of the breast tissue.
Okay, the axilla.
But it's important to remember, tumors located more medially in the inner quadrants of the breast can also drain directly to the internal mammary nodes, those running alongside the internal mammary artery behind the sternum.
Right. And we meticulously assess the axillary nodes during surgery, sentinel node biopsy being a standard part of that assessment now. What about spread to the opposite side, the contralateral breast or axilla? When do we encounter contralateral lymph node involvement?
Contralateral lymph node involvement, especially if there isn't a confirmed primary tumor in the other breast, strongly suggests more widespread metastatic disease. It raises the stakes. There are a few potential mechanisms at play here, although some are definitely less common than others in practice.
Okay, can you walk us through those possibilities? How might it get to the other side?
Well, one possibility, although as you pointed out, we're typically talking about cases without an obvious contralateral primary, could theoretically involve haematogenous spread cells traveling through the blood from maybe a occult primary on the other side, which then sees the lymphatics.
Less likely if imaging is clear, but possible.
Possible. Another route is via the subdermal lymphatics that actually cross the midline anterior to the sternum. Think of it like superficial channels connecting the two sides.
Okay, across the chest wall.
Yes. Then there's a more complex pathway. Spread starting in the ipsilateral internal mammary nodes, traveling through interconnecting lymphatics behind the sternum across to the contralateral internal mammary nodes, potentially even involving the opposite breast tissue transiently, and finally reaching the contralateral axillary nodes. There's a bit of a roundabout route.
That sounds quite intricate.
It is. And lastly, and this is really quite rare in our experience, there's the theoretical possibility of a tumor arising from an embryonic epithelial cell rest that just happened to be trapped within a lymph node during development.
Wow, okay. That last one is certainly an outlier, more of a pathological curiosity, perhaps. The interconnected lymphatic pathway across the sternum seems more clinically relevant in certain scenarios, especially with internal mammary involvement.
Agreed. It's the one we consider more often clinically.
All right, let's shift gears now and discuss distant spread haematogenous metastasis. How does that initial seeding typically occur? How do the cells get into the bloodstream?
Haematogenous spread is critically dependent on neoangiogenesis, the formation of new blood vessels within the tumor itself. This process generally kicks off when a tumor reaches a size of around, say, 1 to 2 millimeters.
Tiny.
Yeah, tiny. Containing approximately 10 to the 5th cells. These new vessels aren't just feeding the tumor. They're leaky, poorly formed, and act as conduits for malignant cells to actually enter the circulation and travel to distant sites. It's absolutely crucial for both rapid growth and metastasis.
And we know breast cancer has sort of favored destinations for these circulating tumor cells. Which organs are most frequently involved in metastasis?
The skeletal system is by far the most common site for distant metastasis. Within the bone, the lumbar vertebrae are involved most frequently. Then is probably the neck of the femur, the thoracic vertebrae, the ribs, and the skull.
So a patient with a history of breast cancer presenting with new onset back pain.
Absolutely. That should certainly raise our index of suspicion immediately. Red flag.
Definitely a key point for our follow-up clinics. What about other visceral organs beyond bone? Where else does it tend to go?
Beyond bone, the liver, lungs, and brain are common sites for metastatic deposits. We also see involvement of the adrenal glands fairly often, and less frequently, the ovaries.
Okay.
It's also worth noting a pattern we sometimes see in limb metastases. They tend to occur above the elbow and above the knee. The thinking is that this correlates with the distribution of active hematopoietic bone marrow in those regions.
That's an interesting correlation with the active marrow-sites. And what kind of effect do these bone metastases typically have on the bone itself? Do they build bone or destroy it?
Good question. The vast majority of bone metastases in breast cancer are osteolytic, meaning they lead to the destruction of bone tissue. You see holes in the bone on imaging.
Right.
However, we also encounter osteosclerotic lesions where there's an abnormal increase in bone density, looks whiter on X-ray, and sometimes you get a combination of both, referred to as mixed-type metastases.
And what happens if the marrow gets heavily involved?
Well, in cases where the bone marrow is extensively replaced by metastatic cells, we can even see something called leukoerythroblastic anemia. This is characterized by the presence of immature blast cells, both red and white cell precursors, spilling out into the peripheral blood. It's a sign of marrow failure, essentially.
A significant complication. And just briefly, are there any emerging markers related to this hematogenous spread that are gaining traction?
Yes, definitely. There's a lot of research into circulating tumor cells, CTCs, and also circulating cell-free tumor DNA, often called cfDNA, or liquid biopsy. These are being investigated as potential prognostic markers and ways to monitor treatment response, though their routine clinical use is still evolving.
Fascinating area. Okay, that gives us a really comprehensive picture of the spread mechanisms. Now let's shift our focus to how breast cancer actually presents to us in the clinic, the common signs and symptoms patients come in with.
Right. So the most frequent presenting symptom, the one that brings most patients through the door, is the self-discovery or maybe clinical detection of a discrete lump in the breast.
The classic lump.
The classic lump. And statistically, the upper outer quadrant is the most common location for these primary tumors.
Why is that?
It's believed to be related to the higher concentration of terminal duct lobular units, the TDLUs, the functional units of the breast, in that specific area. Roughly 50% of the breast's glandular tissue is concentrated there.
Makes sense. That upper outer quadrant always warrants a really meticulous examination during clinic. What are some other clinical red flags beyond a lump that patients might present with?
Okay, so beyond a palpable mass, Nipple retraction is a significant finding, as we discussed earlier, related to that local spread and pulling on Cooper's ligaments.
Yep.
Nipple discharge, particularly if it's bloody or serous, is another concerning symptom. It always requires thorough investigation to rule out an underlying malignancy, although benign causes are more common.
True, but you can't ignore it.
Never ignore it. And then we have the various skin changes. We might observe ulceration of the skin, peau d'orange, that characteristic pitted appearance like the skin of an orange.
Right, the orange peel skin.
Yeah, exactly. Caused by lymphatic obstruction. We might see satellite nodules popping up in the skin surrounding the primary tumor, and of course that dimpling or tethering of the skin we mentioned earlier. I remember one case, actually, where the only initial sign was this incredibly subtle puckering, only visible when the patient moved her arm in a certain way, turned out to be an underlying cancer.
Wow, highlights the need for careful inspection. Let's delve a bit deeper into peau d'orange. What's the specific physiological basis for that distinctive presentation?
Peau d'orange is a direct consequence of the obstruction of the superficial, the cutaneous lymphatic channels. This blockage can be due to direct tumor infiltration of these subdermal lymphatics, or can be caused by compression of the lymphatic drainage pathway by enlarged, involved axillary lymph nodes.
So upstream blockage.
Exactly. The lymph fluid gets backed up, trapped in the interstitial space around the hair follicles and skin glands, and that's what creates that distinctive pitted orange peel appearance.
Okay. And then we have the really advanced local presentation, cancer en cuirasse. That sounds formidable.
It is indeed. Cancer en cuirasse literally means cancer in armor. It describes a scenario with really extensive tumor infiltration of the skin, like a sheet. It's not just localized to the breast anymore, but can involve the chest wall, sometimes the upper limb, even extending down onto the abdomen. It's a sign of very significant local progression and often presents a huge therapeutic challenge.
A very difficult situation. Now, sadly, we still encounter patients, particularly in some settings, who present with symptoms of metastatic disease as their very first indication of breast cancer. Is this more prevalent in certain populations?
Unfortunately, yes. In resource-constrained settings, where screening programs might be less robust or access to healthcare is limited, the proportion of patients presenting with de novo metastatic disease, meaning metastatic diagnosis, can be alarmingly high. Sometimes reports suggest up to 60%.
60%, wow. That really underscores the critical importance of improving screening programs and access to early detection globally.
Absolutely. It's a major public health challenge.
So when we're seeing a patient, maybe with a suspicious finding or even post-treatment, what are the key symptoms we should be specifically asking about that might suggest underlying metastatic spread? What are the review of systems questions we need to hit?
A comprehensive history is just paramount. We need to specifically inquire about any new onset swelling, maybe in the neck or the armpit, which could indicate regional lymph node involvement beyond just the axilla, like supraclavicular nodes.
Okay.
Bony pain is particularly significant. We need to ask about it directly, any new persistent aches or pains, especially in the back, hips, or ribs, as bone pain is the most frequent symptom of distant metastasis.
Got it. Bone pain first.
Definitely. We should also ask about any pulmonary symptoms, a persistent cough that's new, shortness of breath, especially with exertion, or certainly hemoptysis, coughing up blood. These could point towards lung involvement.
Neurologic.
Yes, crucial. Any persistent headaches, visual disturbances like blur or double vision, any new neurological deficits, weakness, numbness, balance problems, or even seizures, especially new onset seizures in an adult. These should raise our suspicion for brain metastases.
Right. Abdominal symptoms.
We need to ask about things like abdominal distension or bloating, jaundice, yellowing of the skin or eyes, or unexplained anorexia, loss of appetite. These could suggest liver involvement or maybe other intra-abdominal disease like peritoneal spread.
Okay. And what about more general systemic symptoms?
Yes, don't forget those. We should be alert to systemic symptoms like unexplained, profound weakness or fatigue, unintentional weight loss, and even symptoms suggestive of hypercalcemia like confusion, constipation, excessive thirst, which can sometimes be a perineoplastic effect of extensive metastatic bone disease.
That's a very thorough list. So pulling it all together, a thorough understanding of these spread patterns, local, lymphatic, haematogenous, and the really diverse clinical ways this disease can manifest is just absolutely crucial for us as surgeons. It impacts everything from diagnosis to staging to formulating the most effective treatment strategies.
Precisely. Recognizing the nuances of local spread informs the extent of our surgical reception. How wide do we need to go? Understanding the lymphatic drainage pathways guides our approach to sentinel lymph node biopsy and, if necessary, axillary dissection. And being keenly aware of the common sites and symptoms of distant metastasis is vital for appropriate preoperative workup, do we need scans, and also for designing effective postoperative surveillance strategies. It guides our follow-up.
Okay, great. Let's try to quickly recap the key points we've covered today. We started with local spread, direct invasion, the role of growth factors like FGF causing that desmoplastic reaction, leading to clinical signs like skin dimpling and nipple retraction via Cooper's ligaments.
Right, the collagen contraction.
Then we explored lymphatic metastasis, mainly to the axillary nodes, but also the internal mammary route and the various pathways for contralateral involvement.
Including that complex transsternal route.
Exactly. Then haematogenous spread, driven by neoangiogenesis, kicking in around that 1-2 millimeter or tenor cell mark. We talked about common distant sites, bone being number one, lumbar vertebrae, femur neck, thoracic vertebrae, ribs, skull, but also lung, liver, brain.
Mostly osteolytic bone lesions, but sometimes sclerotic or mixed, and the risk of leukoerythroblastic anemia with heavy marrow involvement.
Right. And finally, we covered the clinical presentations, the common breast lump, usually upper outer quadrant due to TDLU density, but also nipple changes, skin signs like peau d'orange from lymphatic blockage, ulceration, tethering, and those systemic symptoms hinting at metastatic disease.
And the advanced presentations like cancer on cuirass and the sad reality of high rates of metastatic presentation in some resource-poor areas.
A really comprehensive summary. And keeping these patterns in mind, along with the specific details like, the 1-2 millimeter tumor size for angiogenesis or the order of frequency for bone mets, really allows us to approach each patient, each case, with a more informed and strategic perspective.
Absolutely. It's not just academic knowledge. It directly impacts how we manage patients day to day. It's a continuous process of learning and refinement, really sharpening our clinical acumen to provide the best possible care.
Couldn't agree more. Well, thank you for lending your expertise to this deep dive into breast carcinoma spread and clinical presentation. It's a topic that is so central to our daily practice.
My pleasure. It's always a valuable exercise to revisit these fundamental principles, helps keep them fresh in mind.
Thank you for listening to our podcast. See you in the next episode.